Okay, great. So sorry, I don't know how far I got. I'm Jackie Brady. I'm a sports doc here, associate professor. When I first started practice, I had the immense good fortune of going to the Mayo multi-lig knee course, where I met Dr. Levy for the first time and many of the members of the knee dislocation study group that he's mentioned already. Um, so I actually said to him then that I wanted to invite him out to do a visiting professorship and we should do a lab and it'd be great. And so we dreamed and we were going to do it. And then we had to do virtual. But this is actually really fantastic. And I hope everybody's having as rich an experience as I am. Part of the reason that I signed up for this particular topic is that we're joining the STAR trial, as Dr. Levy mentioned, and that is led by many of the members of the multi-ligament knee study group. Which is like who's who of sort of complex knee surgery. And when I got an email inviting us to join, I said, yes, absolutely. Yes, yes. Where do I sign? And so I met with Dr. Yergang virtually, who is incredibly thorough and organized and meticulous in his research. He is a physical therapist, I think a former athletic trainer. He has a doctorate degree. He's fantastic. And so he's taking me through the sort of inclusion criteria. Great. Where do I sign? Exclusion criteria. Great. Where do I sign? Here we're going to randomize timing of surgery, but also timing of rehab. Fine. Okay, great. And then, by the way, everybody's going to do the same rehab protocol. And just sort of imagine the sort of record stopping. And I said, wait, what? Everybody's going to do the exact same protocol. And he said, yes, partial weight bearing from the jump, essentially. And I was stressed out by that. And so I figured, okay, well, great. This is an opportunity to dive into the literature and to understand this better, because I know this group of people to be very meticulous and very evidence-based. And so there must be some great literature out there that I just haven't run into that I'm going to share with everybody. And so I did. And so I feel like this is what I ran into, that there, in terms of real quality rehab literature, there's a lot of literature out there, and I'll present some of the more salient studies that I ran into. But in terms of the real quality sort of comparative literature, not much. And I think that's part of why we're doing that as part of our study. So I think part of the problem is that the patients are very highly variable. Some of them have a multitude of injuries in their knees, and then some of them have other injuries in their other limbs, in their head, in their belly. Some just have a meniscus and an ACL tear if we're talking about just sports literature and rehab. So most of the literature I encountered was level 5 evidence or something close to that, like a cohort group or something like that. So let's sort of talk about what we know. I think part of the problem also is that these are apples and oranges in terms of patient habitus. Like weight bearing for sumo wrestlers on the left and right of Novak Djokovic, the tennis player here, is going to be a very different scenario than for this very lean, lighter guy. And really, truly, these are all elite athletes, but it's a big variable that I think is hard to quantify. So the two sticking points that I want to focus on that made me hesitate in this conversation were PCL reconstruction, because I'm in the school of Bob Marks, who's very conservative about rehabbing his PCLs. I don't know if he's evolved from that. Maybe I should reach out to him. But with HSS part of the knee dislocation study group, I suppose he's probably being a little more aggressive. And then complex meniscus repair, i.e. root tears in particular, radial tears, or some of these sort of save the meniscus type of interventions. So speaking of what we know, let's just sort of back off of weight bearing strictly for now. And we learned at Journal Club and spoke about the fact that if your bony anatomy is normal, then full knee extension should be a safe position for that knee in terms of ligament shear and shear on the cartilage and stress on your reconstructions. When the knee starts to bend, it's not a pure hinge. It both rolls and glides. And when the ligaments are compromised or newly reconstructed, that leaves the knee at risk for instability or failure. So there are 2 points that I just want to emphasize for the residents. Juniors may or may not have encountered this yet. It's spoken a lot about in the total knee literature because we're trying to recreate this normal knee kinematic sort of pattern. Femoral rollback happens when the knee bends, where the contact point between the femur and the tibia moves posteriorly the more you bend. And that, those of you who've been in clinic with me have heard me say, you're going to squish my meniscus repair if you're going to bend your knee into deep flexion, or loaded in deep flexion, if you're a little farther out in your rehab. And then on the other side, when you extend your knee, there's rotational motion that happens because the medial femoral condyle is longer than the lateral femoral condyle. So you get this internal rotation of the femur, external rotation of the tibia, and terminal extension. So because of these phenomena, you'll find that most of us, if we do allow weight bearing, are going to have our patients keep their knees straight initially to protect our surgeries. And what if they don't bear weight but pursue motion? You guys heard Dr. Levy reference 2 different very accomplished knee ligament surgeons and 2 very discrepant rehab protocols for post-operative motion and weight bearing. If you're not putting weight on your knee and you're pursuing motion, then different motions are going to create shear, and particularly with the cruciates, right? Because the collaterals hopefully aren't seeing shear if you've got them in a brace. But if you aren't loading the knee and you're just flexing the muscles, we know that from 1995, we've known that the gastroc contraction at greater than 30 degrees of flexion is going to shear on your PCL. And I mean, think about all the patients that we have them wiggle their toes, right, to prevent blood clots. Wiggle your toes, wiggle your toes. That's contracting your gastroc. And so if they're doing that in flexion, then that's shearing on their PCL reconstruction. And then the more passive flexion you do, the more tension is on your PCL. Quad activation is protective for the ACL. Just a quick note about for the PCL. For the ACL, the early flexion, so short arc quad contraction is going to create the most shear. So from 0 to 60, this comes up on OED once in a while, the short arc quad is going to shear on your ACL. So hamstrings load the PCL and protect the ACL. Quads load the ACL, protect the PCL. So from this standpoint, maybe some weight bearing is beneficial. This is an intentionally busy slide. This violates Dr. Levy's rules of slides for presentations. This is just a figure from the study mentioned below. That's a review of all the available post-op protocols in 2012. I haven't found anything more recent.
Tables are okay. Tables are okay. Green light.
Excellent, thank you. I suspect if we did this again today, we'd have even more to choose from and even more variability. You get the feeling that there's a lot of difference in sort of weight bearing range of motion restrictions, what you're activating, whether it's open chain, that OKC, open kinetic chain, and closed chain. Oh, just an aside, for junior residents who might not have encountered it, open chain means your foot is not planted on something. Closed chain means it is. So think like knee extension machine versus like a squat. So if you look though at the weight bearing portion of this table, you might be reassured that early weight bearing might be safe in the setting of PCL. Because a lot of people are doing it and they seem to have reasonable outcomes. And so that sort of gave me some reassurance overall. So let's pause on PCL and think about meniscus for a minute. We know that the amount of load that the menisci see is different, which pretty much reflects the relative contact area in the compartment. So medial meniscus is more stable. I think with the medial compartment of the knee is more of a translational compartment. The lateral meniscus sees a lot of load because it has fewer meniscocapsular attachments. And then the menisci function by these hoop stresses, right? Most of us know that they attach to the tibia by their roots, anteriorly and posteriorly, and you load them like a hula hoop by stretching them as you put weight into this hoop. So from that standpoint, the complex meniscus repair makes me a little nervous that if something has violated those hoop stresses and I'm trying to Hail Mary that thing to heal, then loading that makes me worry that I'm going to disrupt those hoop stresses all over again. There's a myriad of smallish cohort studies. I think they're very respectable bits of literature. Single surgeon a lot of times. You'll see like 30, 40 patients. One of them has 60 patients. And you can kind of see that conservative approach has some failures, accelerated approach has some failures. They don't seem to differ a whole lot. And so I was kind of left with this question mark in my head. And these studies, all of these in this list, have sort of peripheral vertical tears that are well vascularized and sort of the standard repair. And what do we do with this whole Save the Meniscus campaign that the AOSSM is promoting, where if you're trying to get a radial tear together or you're trying to get a root back together, you could look at this horizontal cleavage tear, this sort of typical like mucoid degeneration, horizontal tear parallel to the joint line. You put some sutures around that. You have them weight bear on it. Sure, that squishes it. That probably makes everybody feel pretty good. But the radial tear and the root tear, I feel like we're sort of putting ourselves at risk here. So there's a great study out there by our own Sam Moulton and Dr. Laprade that just sort of goes through all the rehab options for root repair. And there's no real clinical comparison. As I mentioned, the rehab literature just hasn't gotten there yet, comparing weight bearing to non-weight bearing or partial weight bearing. But we know that hoop stresses strain the meniscus roots. We know that cyclic loading causes micromotion in the repair itself, and that small errors or displacement, so like putting the root back where the root wasn't originally, or displacement of the root when you repair it, might have deleterious effects. So thinking about it biomechanically, it raises an eyebrow. And then there are two salient clinical studies out there. One in 2011 looked at immediate partial weight bearing for only 14 patients. And on second look arthroscopy, 3 of them were loose and 2 of them had loss of fixation entirely. And they described hoop tension loose in 2 of the knees and lost in 2 of the knees. So, I mean, pretty concerning percentage of failures there. And then compare that to a study in 2009, again, only 21 root repairs, but non-weight bearing in the first 6 weeks, only 1 of those patients retore. So it kind of makes you wonder. But maybe this is the bottom line. And I think looking at the article that came out from Dr. Irgang's initial sort of here's how we're doing the STAR trial paper, patients don't listen to us. I think that's just the global sort of truth in orthopedic surgery and in medicine. They can't really comply with partial weight bearing and touchdown weight bearing. They don't use a consistent amount of weight when we're instructing them to limit their weight bearing in any way. And there's a fair amount of literature out there in the trauma world that if we tell them to limit their weight bearing, same thing, same problem. And there's no data in the multi-leg knee population to support non-weight bearing. And there are benefits to weight bearing. There's real harm to atrophy and sort of the disuse of the limb. So chondral health, meniscal nutrition, those suffer when you take the weight off the limb. And so that's, I think, where the STAR trial landed. They said dose the weight bearing to tolerance based on the presence or absence of the cardinal signs of inflammation of the knee. So they lock that brace in extension for the first 6 weeks. And they allow the patient to weight bear as tolerated. Then they unlock that brace after 6 weeks when the straight leg raise doesn't have a lag anymore, i.e. the quad function has normalized. I gotta say, I'm kind of convinced on PCL. I'm interested to know Dr. Levy's thoughts on this as a member of the STAR trial and a multi-leg knee surgeon himself. But I still worry about those roots. I still worry about those complex menisci. If we're trying to sort of save the meniscus with this whole AOSSM campaign, where do we go with putting weight across it when we're trying to really coax those hoops to get back intact? So that's what I've got. Discussion is welcome. I would love to hear it, and thanks so much for your attention.
That's a wonderful review. Slides are awesome. I will pay you for that talk. That talk is absolutely outstanding.
I will gladly support you. Absolutely.
Oh, yeah, that's fantastic. So when we were developing the trial, I don't think there was anything, well, there were 2 things that generated hours of discussion.
Oh boy.
One was weight bearing after root tears or radial tears, and the other was distally based fibular head avulsions.
Ooh, yes.
So randomize early versus late surgery.
Yeah.
So here's the thing. Number 1 is there is a little section when you're filling out the inclusion criteria for soft tissue injury that precludes early rehabilitation. So if you as a surgeon feel strongly that you've got a complex meniscal tear that is in the radial plane and you got like an okay reduction, or you fix the root in an older patient and it's not that great, you check that box and patient is out of randomization. So you can randomize them for the early versus late surgery, but you've got an out if you don't feel that you're comfortable randomizing them to early versus late rehab.
Oh, good.
I also think, Jackie, and I'd have to look back at this, but it seems to me that we had agreed that if you had a root repair and you were in the early rehab group, that you could still limit their weight bearing, but do everything else the same. I have to look back on my emails and maybe we can ask Jim about that, or Jay about that.
Yeah, I was on a call with Brian Waterman and Jay Ergang, and I asked them that specifically, and they did not seem to think that that is still the case. But maybe there's still a loophole.
Well, the loophole is if there's any soft tissue injury that precludes uh, your comfort to put patient in harm's way, then you just check that box.
Right.
And actually, we're doing very, very well on the early versus late rehab. It's really a standard versus accelerated rehab program. And
Yes.
where we're falling short on randomization is early versus delayed surgery. And
Right.
that's because people come to us late, and more importantly, they have this preconceived notion that they need to be fixed right away because everybody's planted that seed with them. And
Mhm.
they also think it's going to delay when they can get back to work or sport. So it's a much, much harder sell. In that line, we made it, 0 to 6 weeks versus 12 to 16. So there's
Right.
only like a 6 week difference, but in people's minds are like, I just want it done.
Right.
So, if you check that box and they get out of the rehab arm, not the end of the world.
Okay. That's great to know. Thank you.
But we're excited to have you and Brian. There's when we started this, I was mentioning that the first emails were like gosh, we're talking, 10 years ago we started developing this. It was actually, I can tell you exactly when. It was 2013 when
Okay.
I got invited to Washington, D.C. to speak to a group of senators responsible for the defense budget on what a multiple ligament injury knee is and why they should fund a big study on it. And then it took another, gosh, 6, 7 years before things
Yeah.
got underway. It's a long process, but it's really
Yes.
worthwhile.
And it sounds like, I mean, he described the thoughtful, like, sort of consideration of all these details, like the meeting that you guys had to just design the study
Oh,
was very lengthy, wasn't it?
oh.
It was
We had,
exciting.
yeah, we had two in-person meetings, and we had a whole big talk about clinical equipoise, like we talked about with Journal Club, because if
Right.
you start pre-selecting patients out, so that's where we have a few loopholes in there, with that soft tissue injury that precludes randomization.
Gotcha. That's fantastic. Yeah, we're really looking forward to joining. I was lamenting for everybody else the timeline of it, but then Dr. Levy told me how long it took Mayo to get up and running with the study, and I felt a little better.
Oh, oh yeah, it's especially when data is not being housed at your own institution.
Yeah.
There's just way more loopholes when you have patient data from your institution that's being housed, in Pittsburgh.
Right.
So there's just a lot of checks and boxes, and well, once you're up and running, it's not that tough. The toughest part is the time it took for Meteor patients. My God, it would add an hour for every patient for Meteor. The
Really.
STAR trial probably adds a half hour. We have a video now that we've made. And so after we talk about the trial while we're waiting for the study coordinator, we have them watch the video. And in the video is a military veteran that talks about how important it is that she felt that she needed to be in the trial and
Wow.
how a privilege she felt to be involved. I mean, it's really like inspiring. So I think they did a wonderful job with the video. So that'll help randomization.
Definitely.
Excellent. Thank you so much, Dr. Brady, and we're very excited to be joining that trial and getting through all the paperwork, and that's really exciting. So, a really great opportunity.